Hi, my name is Tara, and in this video I will explain cystic fibrosis. Go ahead and push away all distractions. I will explain processes due to misfolded proteins, additional related cell and tissue activities, how cystic fibrosis is diagnosed, and potential treatments. So, what is going on at the cellular level? Well, usually it starts with a missense mutation. Tiny little mistake in the DNA causes the proteins to not fold properly. So these misfolded proteins will accumulate in the endoplasmic reticulum, where they are then either degraded or fixed with the help of chaperone proteins. Sometimes translation will slow down and the number of chaperones will increase, giving these chaperones a chance to fix the affected protein. If this response is insufficient, then the cell will self-destruct through a process known as apoptosis. Interestingly, ATP is required for many of the foldases, which are a type of chaperone proteins. Therefore, oxygen deprivation can cause this response to be insufficient. Age is another important factor. The symptoms in cystic fibrosis are primarily due to abnormal chloride and bicarbonate transport by the CFTR channel, altering luminal fluids both directly and indirectly. So this CFTR channel is the protein that is affected. As a result of this insufficient ion transport, viscous secretions will accumulate in various organs. The CFTR channel has two transmembrane domains, which you can see at the top. These form a channel that is permeable to chloride and bicarbonate ions. There are also two nucleotide binding domains, which you can see at the bottom, and a regulatory domain in the middle. ATP, which is a nucleotide, can bind to these nucleotide binding domains, and that will cause them to dimerize, therefore opening the channel. These nucleotide binding domains will then hydrolyze the ATP, so that a phosphate is kicked off. And then you are left with ADP. That will cause the dimer to dissociate so that the channel is closed. Protein kinase A, or pKa, can bind to the regulatory domain, and that will release the regulatory domain from its inhibitory position. But then phosphorylation of protein kinase A can make this activation irreversible. The full name of the CFTR channel is the Cystic Fibrosis Transmembrane Regulator. Cystic fibrosis, because that is the disease involved. Transmembrane, because the protein is embedded in the cell membrane. Regulator, because it is regulating ions. Here's a simplified drawing I made for the next demonstration. Feel free to sketch this yourself if you like. Normally, the CFTR channel will allow chloride and bicarbonate ions to leave the cell, moving from the cytosol into the lumen. And of course, the lumen could be your airway, or the inside of your intestines, or the inside of a duct where something is being secreted. So remember, in cystic fibrosis, we don't have enough of these channels in the membrane because they had a mistake and they didn't make it to the membrane. So because there's not very many, this transport is not going to be very efficient. So with these basic ions not making it into the lumen, the secretions in the lumen are going to be rather acidic. But it turns out that the CFTR channel also regulates other channels. It usually downregulates the epithelial sodium channel. So in cystic fibrosis, this epithelial sodium channel is not downregulated enough, meaning that we have too much sodium entering the cell. And because water follows sodium, we also will have passive water uptake as a result. So because the water followed the sodium, this luminal fluid is still going to be balanced in that it is isotonic, but it's going to be low in volume because we lost all that water, so it's going to be viscous. And if you're not familiar with the term viscosity, just think of honey. Honey is more viscous than water. It's kind of thick and gooey. Interestingly, though, the opposite happens in the sweat ducts when it comes to the epithelial sodium channel. The activity is decreased by the mutation in that case. And so, as a result, their sweat will be salty. In your airway, you have these small little projections called cilia that will help keep mucus moving in the proper direction so that any junk you get in your airway, hopefully you can swallow. But this dehydrated mucus that's viscous is going to cause these cilia to not work very well. It's just a lot of resistance there. And so this viscous mucus will actually accumulate. There also can be mucus hypersecretion, and this is not well understood, but it may involve inflammatory mediators and an increase in goblet cells, which have secretory granules that store mucins and release them by exocytosis. Due to the resulting injuries, a change in gene expression will cause these immune cells called fibrocytes to deposit excess collagen so that scar tissue increases in organs over time. I made this flowchart to explain what happens in the pancreas. First, a duct, such as this pancreatic duct, may become clogged. If it's completely clogged, the gland will atrophy and there will be resulting fibrosis. If it is partially clogged, then there will be a loss of pancreatic enzyme secretion. If you don't have enough pancreatic enzyme, you're going to have malabsorption. If you don't get enough proteins, you're going to have edema. And if you can't absorb enough fat, then you're not going to absorb enough of the fat-soluble vitamins, such as vitamins A, D, E, and K. And that can cause stunted development if you don't get enough of those. Avitaminosis A may also contribute to squamous metaplasia of the pancreatic duct epithelium. That is basically a change in the type of cells, so that they are replaced by a different shape of cells. This metaplasia may also occur in the salivary glands, leading to fibrosis. If the little channels for bile called canaliculi are clogged, then the duct will proliferate. It's going to grow. That can cause inflammation of the hepatic portal system. And as a result, there can also be hepatic steatosis, known as fatty liver disease. But as with any disease, modifiers are really important. There are many factors that can affect the severity of cystic fibrosis. One of them is Pseudomonas aeruginosa. It's a gram-negative bacteria that occurs in 80% of cystic fibrosis patients by age 20. It colonizes the lower respiratory tract, and it thrives in that static hypoxic mucus microenvironment. That's because that microenvironment is ideal for alginate production, which is important for creating the polysaccharide capsule, which creates a biofilm that protects the bacteria from both antibodies and antibiotics. Then there will be an immune response, but it's ineffective because of this. And so this ineffective immune response wreaks havoc on the lungs, and the fibrous tissue replaces the destroyed functional tissue. This is a growing concern because this bacteria is the main cause of death in cystic fibrosis patients. A study found that 21% of hot tub and swimming pool samples had this bacteria. And of these samples, all isolates were resistant to at least one of 9 antibiotic agents tested, and 96% of the isolates were multi-drug resistant. It turns out that the complex piping is hard to clean, and hospitals also pose a threat. But the good news is that there are more drugs out now since that study. And there were only 108 samples, 3 hot tubs, 8 indoor pools. So it may not be as bad as it looks. Maybe a higher sample size would show different results. But it still is, something to look at, possibly be concerned. This P. aeruginosa is a big deal in hospitals because it's actually the second leading cause of gram-negative hospital infections. Another important factor is smoking, and it can actually lead to a lot of the symptoms of cystic fibrosis, even in patients that don't have the disease. Also, the neutrophil genes are important. If you have cystic fibrosis, basically how healthy your neutrophil immune cells are going to be a big factor. So, how is this disease diagnosed? Well, often they will look at family history because this is a congenital disease. Also, distal intestinal obstruction may occur, which will present as lower right quadrant abdominal pain and sometimes a palpable mass. Also, the sweat electrolyte level, as we talked about before, is the sweat salty? Does it remain salty? And then a really good one is the blood level of the pancreatic enzyme trypsinogen. If it is high in a newborn, that is an indicator that their pancreas may be injured. Sometimes during their first year of life, they will have large, stinky stool, perhaps a distended abdomen, and poor weight gain. A really good test that they have now is the nasal transepithelial potential difference. Again, because we're talking about ions, it's a great way to measure the ion transport. But of course, the gold standard with any genetic disease is sequencing to see if that mutation is present. There are a few different therapies, such as antimicrobial therapies, pancreatic enzyme replacement, and lung transplants. And there are new agents being developed. There are a few different types I will talk about. There are potentiators, which will help keep that channel open. There are correctors, which assist in the folding of the proteins. Read-through aids, which would bypass premature stop codons, could be one type of mutation. Also, amplifiers can increase the CFTR channels so that hopefully as a result, there will be more functional channels that reach the membrane. And there was a combination of a potentiator and corrector that was approved for a certain cystic fibrosis mutation. Here are my references. Thank you for watching my video. Happy studying!